Hello, everyone, and welcome to this FIP digital event. So good morning, good afternoon, and good evening to you, wherever you are joining us from. Also to those listening to us after this event. I'm really very pleased to welcome you to today's event, Empowering Pharmacists to Prevent HPV-related diseases and cancers and educate patients. So my name is Hannelie Meyer. I'm a professor in the School of Pharmacy and head of the South African Vaccination and Immunisation Centre, SAVIC, at Sefako Makgatho Health Sciences University in South Africa. So with me, I have Hannelie from Unit WIN and Provision Coordinator at FIP in the Netherlands. So Hannelie and I will be co-moderating this digital event. So we really look forward to guiding you through the presentations and discussions and encouraging active participation from all of you. So before we begin, I would like to share some housekeeping announcements from FIP. So firstly, this webinar is being recorded and live streamed via YouTube. The recording will be available on our website at events.fip.org. And then you may ask questions using the question box provided. You are also welcome to provide feedback via email to webinars@fip.org. And if you would like to become a member of FIP, please visit www.fip.org/membership_registration. Now, just a quick note for all our attendees. So Zoom has a built-in translation feature, so you can follow the presentation with live translated captions. So please follow these steps as you can see them shown here on the screen. So firstly, turn on captions. Thereafter, enable the translation toggle. And then lastly, choose your language under My Caption Language. Good. So now let's begin with our agenda. We'll start with this welcome and introduction. Next, we will then have Hannelie Alulimi. She will provide an overview of the CPD Bites series and our communication guide. We will then move to our main presentations by three different speakers on the basics of HPV and transmission, on vaccine safety and effectiveness, and then also on the pharmacist's role in HPV vaccination and cancer prevention. So following the presentation, we'll have a Q&A session where you can then ask your questions to the speakers, any questions that you may have. So as we move on with the presentations, you can already put your questions in the Q&A box. So finally, we will then wrap up the event with some concluding remarks. So here you can see our objectives for today's session. So firstly, we aim for you to gain a solid understanding of HPV, its transmission, and its role in causing various cancers. Secondly, we will explore the safety and effectiveness of the HPV vaccine in preventing HPV-related diseases and cancers. Thirdly, we will highlight the crucial role that pharmacists play in HPV vaccination and cancer prevention. And then finally, we are very excited to introduce FIP's new HPV CPD Bites and Communication Guide. So now I would like to start introducing our esteemed panelists. So firstly, joining us all the way from Australia is Dr. Rawan Mayis, obstetrics and gynecology trainee from the Royal Australian and New Zealand College of Obstetricians and Gynecologists. Then myself from South Africa, And then we have all the way from the United States, Oluchukwu Maureen Eziala. She's a PhD student, research assistant from the Department of Health Outcomes and Research and Policy at the Auburn University Harrison College of Pharmacy. I am now going to hand the floor over to Hannelie. Thank you.
Thank you very much, Hannelie, for the kind introduction. It's my pleasure to co-moderate this event with you. I would like also to extend my gratitude to our esteemed panelists and participants for joining us in this informative and impactful session. My presentation today will focus on FIP's work on vaccination and to use this opportunity to launch our new resources on human papillomavirus HPV. Okay, here I will start my presentation by highlighting one of FIP's priority programs, disease prevention, that focuses on advancing pharmacist roles and strategies that keep people healthy, functional, and productive. So this program emphasizes the prevention of infectious disease through vaccination, vector-borne, and disease control, and also addressing prevalent infections like HIV, AIDS, and tuberculosis. Okay, here, what also I want to mention the development goal, the FIP development goal 21 launched in September 20. Vaccination is linked to 17 goals, which indicates the high priority vaccination holds not only for pharmacy and FIP, but also for global health. Development Goal 16 focusing on communicable diseases and is clearly linked to prevention of this group of disease in which vaccination play a prominent role. Here, I would like to take a moment to acknowledge our dedicated team behind the FIP vaccination program. Thank you for all your support and invaluable contributions. Okay, so taking you through a quick summary of some of our important work on vaccination from the past year. In April 2024, we launched the Global Intelligence Report on the role of pharmacists on vaccination based on data collected from 116 countries and territories on pharmacist-led immunization practice worldwide. Vaccination, including advocacy activities, regulatory frameworks, vaccine administration and prescribing authority training and certification, access to vaccine records, remuneration models, and finally, barriers to expanding services within pharmacy practice. We also launched a campaign by FIP called Think Vaccination, Think Pharmacy, which is part of a larger campaign called Think Health, Think Pharmacy. Our goal in this campaign is to invite governments, policymakers, member organizations, and all stakeholders to consider how pharmacists are making a huge contribution to vaccination delivery around the world. Also, in October 2024, we launched an advocacy brochure aimed at policymakers. This brochure outlines key facts, figures, and advocacy messages on the importance of the role of pharmacy in life course immunization based on our recommendations from the policy statement on life course immunization, as well as data from our intelligence report. Another advocacy pager was launched with recent FIP resources presenting robust data and case studies on pharmacy-based vaccination worldwide, particularly two landmark reports and the FIP online atlas on pharmacy-based vaccination surveillance. FIP launched several initiatives in late 2024, including video testimonials on pharmacy-based vaccination, a podcast on vaccination and pharmacist roles, a video presentation advocating for global pharmacy-based vaccination implementation, and the CPD Byte implementation, and the CPD Byte on pharmacy-based vaccination services, So these initiatives promote pharmacists' role in global vaccination efforts. Last but not least is the FIP Pharmacy-Based Vaccination Surveillance Atlas is an open access interactive tool providing detailed data on pharmacy-based vaccination services around the world. You can explore country profiles, summaries, maps, and graphs based on FIP member contributions. Okay, so now and today, which is the March 4, marks the International HPV Awareness Day. This important day aims to educate people about HPV, which is the human papillomavirus, its dangers and preventative measures, especially through vaccination. Pharmacists are key players in preventing and managing HPV. As part of our efforts to prevent communicable diseases, we would like to take this opportunity to launch our new resources to help pharmacists contribute more effectively to public health initiatives. These resources, which we will explore in the upcoming slides, are designed to empower pharmacists in their efforts to fight communicable diseases like HPV. So as I mentioned, in recognition of this important day, today we are launching a series of 3 educational videos aimed at enhancing pharmacists' understanding of HPV-related cancers and diseases. These resources aim to enhance pharmacists' knowledge and engagement in addressing HPV-related cancers and diseases by improving their education on HPV vaccines and supporting vaccination advocacy. Now here, the first episode presented by Dr. Rowan Bajes provides a comprehensive overview of the human papillomavirus, covering its biology, routes of transmission, and the spectrum of associated cancers and diseases. It emphasizes the critical role of both vaccination and screening programs in preventing HPV-related diseases. And the second episode, presented by Professor Hannelie Meyer, focuses on HPV vaccination, covers the vaccine's mechanism, its high effectiveness in preventing HPV infections and related cancers, and its safety profile. Her episode also addresses the gender-neutral vaccination and highlights the importance of clear communication to build vaccine confidence and debunk myths. The last but not least of our series today is the third episode presented by Searling Professor Sarisa Wistrick, focuses on the critical issues of HPV vaccination, highlighting the global impact of HPV-related diseases and cancers and emphasizing disparities in vaccination rates across regions, socioeconomic groups, and sexes. In addition to that, to mark Cervical Cancer Prevention Week in January 2025, early this year, we have launched a concise communication guide for pharmacists and healthcare providers discussing HPV and vaccination benefits. This evidence-based tool helps start conversations with open-ended questions, build vaccine confidence, and provide clear facts about HPV and its health impacts. In conclusion, you can find all of these resources and much more on our webpage, Pharmacy-Led Disease Prevention. I encourage you to download and explore this valuable resource, which offers a comprehensive toolkit for pharmacists to enhance their role in public health initiatives. So for now, I would like to introduce our first panelist and one of the experts from our CPD bites, Dr. Rowan Bajes. Rowan Bajes graduated with a Bachelor of Medicine and Surgery in 2014, and she is currently completing her specialist training in obstetrics and gynecology. She is currently undertaking a fellowship in pelvic floor reconstructive surgery. Rowan, the floor is yours. Thank you very much.
Thank you very much. Hello, everyone. It's a pleasure to be with you all here today. Thank you to Hannelie, FIP, and the organising committee for allowing me the opportunity to speak to you about HPV and HPV-related diseases and cancers. During this presentation, I'll be speaking to you about human papillomavirus, or HPV, and its transmission, identifying the different types of cancers and diseases caused by HPV, including cervical, oropharyngeal, and other cancers affecting both males and females. I will spend some time discussing the morbidity and mortality associated with HPV, the burden of HPV-related diseases globally, and the fundamentals and importance of vaccinating against this virus. Human papillomavirus is a group of more than 200 non-enveloped DNA viruses. HPV is contracted via exposure and direct contact with infected epithelial cells. It specifically infects epithelial cells in various parts of the body. These include the cutaneous epithelial cells of the skin, such as the face, hands, and feet, and mucous membranes, including the respiratory tract, including the pharynx, nasal, and oral cavities, and the anal and genital tract. HPV can affect both men and women, and it is the most common sexually transmitted infection globally. The primary route of transmission is sexual transmission, and this occurs through sexual activity, including vaginal, anal, or oral sexual intercourse through skin-to-skin transmission. It can occur from the first sexual activity and occurs for only one sexual partner. Statistical data indicates that about 80% of sexually active men and women will acquire HPV at some point in their lifetime. The second route of transmission is non-sexual, called vertical transmission, and this involves a transfer of the virus from mother to child during childbirth, potentially causing the development of respiratory papillomatosis in the neonate. HPV can be transient or lead to persistent infections, which may cause benign lesions or progress to malignant neoplasms. There are over 100 HPV subtypes, and 40 of which are known to infect the lower genital tract. HPV 6 and 11 are considered non-oncogenic or low-risk types, and they are responsible for about 90% of the genital warts diagnosed, but do not contribute to the development of cancer. Higher risk oncogenic types, such as 16 and 18, however, are associated with persistent HPV infection and are associated with 70% of all cervical cancers. Most HPV infections are asymptomatic. However, the symptom depends on the HPV type. Benign lesions such as skin warts are usually painless raised lesions. The presence of benign respiratory papillomatosis may cause changes in voice and breathing difficulties. High-risk HPV lesions can lead to cervical dysplasia or your precancerous lesions, which may present with abnormal vaginal bleeding, postcoital or after sexual intercourse bleeding, or abnormal vaginal discharge. Cancerous lesions may present with abnormal vaginal bleeding, discharge, abnormal vaginal discharge, or in signs of invasion, such as blood in the urine and constipation or pain. HPV is implicated in a variety of cancers and diseases. It is responsible for over 99% of all cervical cancers, with HPV 16 and 18 responsible for over 70% of cases. There is, however, a long latency period between getting the precursor lesion, such as a cervical intraepithelial neoplasm, or CIN, which can be detected with cervical screening testing or HPV testing. It is responsible for 90% of anal cancers, 25% of vulval cancers, 50% of penile cancers, and 60% of oropharyngeal cancers. There is a higher incidence of these cancers in young, non-smoking individuals, for example. HPV 6 and 11 are responsible for the majority of genital warts, but infection rarely leads to the development of actual cancer. The interval between infection and development can take upwards of 15 to 20 years. The mechanism from exposure to the virus to malignant transformation is complex. So let's have a look at the cellular level. Epithelial cells line the outer surface of our organs and blood vessels. The HPV life cycle is restricted to the cervical epithelium. At the skin, genital tract, and respiratory tract, the epithelium is stratified, meaning it has more than one layer of cells. At the base or closer to the interior of the body, the stem cells are less mature and they're rounded stem cells called the basal cell layer. Basal cells divide and replenish all the cells of the epithelium. As the basal cells divide and mature, they move upwards to the outer surface, flattening out and are now called squamous epithelium. The cells are then shed or exfoliated from the epithelium. Typically, the basal cells are protected from the outer surface. However, if there are cuts or microabrasions, HPV can infect the basal cells directly. It then can use host cell machinery to replicate viral DNA and express virally encoded proteins which cause dysregulation of tumor suppressor genes. Finally, the new virus assembles into the upper part of the epithelium, and the virus is released with the cells as they shed from the epithelial surface. It is important to note that HPV does not replicate in the blood, and the infection is not spread systemically. As mentioned before, cervical cancer has a long precancerous phase with cytological changes which progress through different grades, definable cytological or histological features such as dysplasia or CIN. It is very rare to find dysplastic changes in the cervical epithelium within 2 years of first onset of sexual activity. It generally takes 3 to 5 years for the change to progress from one grade to the next, for example. The mean time from detectable cytological abnormality to the development of invasive cancer may take as long as 15 to 20 years. And many cervical enteroepithelial neoplasm lesions will regress spontaneously over time. In the absence of any intervention, roughly 1/3 of early precursor lesions will disappear spontaneously, 1/3 will persist, and 1/3 will progress to CIN3 or from CIN3 to invasive cancer. There are several risk factors for acquiring HPV and having a persistent infection. These include having gender and sexual practices. So both men and women are at risk of HPV-related cancer. Having multiple sexual partners or early onset of sexual activity increases the likelihood of sexual exposure. Men who have sex with men have a higher incidence of anal cancers. Immunocompromised people, such as those suffering from HIV or AIDS, or those who are on immunosuppressive medications, are more at risk of persistent HPV infection and the development of HPV-related cancers. And smoking. Smoking is a known cofactor that enhances the persistence of HPV infection and increases the risk of cervical, head, neck, and anal cancers. And lack of HPV vaccination. So not being vaccinated also increases the chance of acquiring and having persistent HPV infection. In most cases, the immune system clears HPV. 50% of people will develop antibodies against the virus following infection, but it can take upwards of 18 months to seroconvert. Persistent antibodies, however, through natural infection do not confer complete protection. And regardless, over 80% of HPV infections are transient, asymptomatic, and resolve spontaneously. Persistent HPV infection can cause abnormal cells to develop on the cervix, for example, which leads to cervical cancer if left untreated. The HPV vaccination was developed by Ian Fraser in Queensland, Australia in the 1990s. In 2006, the TGA approved the vaccine Gardasil, and in 2007, Australia became the first country in the world to roll out the national HPV vaccination program. The vaccine contains no viral DNA or RNA and therefore is non-infectious and non-oncogenic. When injected into humans, it produces a large number of neutralizing antibodies that are HPV type specific and at far greater numbers than achieved through natural infection alone. HPV vaccines protect against the most common oncogenic strains and those responsible for genital warts. Cervical cancer diagnosis in Australia and New Zealand have fallen dramatically as a result of HPV vaccination and cervical screening. It is estimated that by 2035, cervical cancer is likely to be eliminated as a public health issue in Australia. The World Health Organization recommends that HPV vaccine for girls aged between 9 and 14 before the onset of sexual activity, with catch-up programs for older individuals in certain age ranges. As of 2021, approximately 40% of girls worldwide had received the HPV vaccine, with higher coverage in high-income countries noted. There is no treatment or cure for HPV infection, and it is why it is so vitally important that people are vaccinated and participate in screening. Globally, cervical cancer is the fourth most common cancer in women. Each year, more than 500,000 women are diagnosed with cervical cancer, and 300,000 succumb to the disease. 80% of these cases are in women who have never or never screened, and over 90% of deaths occur in low and middle income countries, largely to underscreened or never screened women or unvaccinated women. This disease, therefore, is largely preventable. In high income countries, cervical cancer incidence and mortality have halved. The economic burden of the disease is related to screening, diagnosis, and treatment, and the indirect costs related to productivity and long-term healthcare costs. In summary, HPV is a widespread virus that causes both benign and malignant diseases. It is the primary cause of cervical cancer, as well as several other cancers, including oral, anal, and penile cancers. Vaccination, regular screening, and treating early precancerous lesions are critical strategies for reducing the burden of HPV-related diseases. The global burden of HPV-related diseases remains significant, with substantial economic and social impact, particularly in regions with limited access to vaccines and screening programs. Thank you.
Thank you very much, Dr. Varan Bajes, for the insightful presentation and for providing the introduction on HPV. Now, I will go to, and it's my pleasure to introduce our next panelist and co-moderator, the esteemed Professor Hannelie Meyer. Hannelie Meyer is a professor in the Department of Public Health, Pharmacy and Management at Sefako Makgatho Health Sciences University, and head of the South African Vaccination and Immunization Center at SMU in the South Africa. She chairs the Ministerial Advisory National Immunization Safety Expert Committee, serves on the National Advisory Group on Immunization, the board of the South African Health Products Regulatory Authority, and the WHO Global Advisory Committee on Vaccine Safety. She specializes in vaccine safety, vaccine hesitancy, and vaccination as a pillar of antimicrobial stewardship. She is a National Research Foundation rated scientist, and her research aims to strengthen healthcare services, improve public health, and contribute toward reaching the Sustainable Development Goal of good health and well-being. Dr. Hannelie Meyer, the floor is yours. Thank you very much.
Thank you very much, Hannelie, for the kind introduction and invitation to participate in this very, very important event and on this very special day that we are celebrating and creating awareness about HPV. I'm always delighted to speak about HPV vaccination, and today my presentation will focus on the safety and the effectiveness of HPV vaccines. So for transparency, I disclose these potential conflicts of interest and confirm that this presentation represents my own views. So by the end of this presentation, you should be able to describe the safety profile of HPV vaccines and identify the most commonly reported side effects. You will gain insight into the effectiveness of HPV vaccines in preventing HPV infections, genital warts, and cervical cancers. The presentation will cover the long-term effectiveness of the HPV vaccine and duration of protection against HPV. And then lastly, you will learn about the recommended HPV vaccination schedules for different target populations. So as background, although Dr. Rowan has already explained some of this, let's just review again how HPV vaccines prevent HPV infections and related cancers. So these vaccines are prepared from L1 structural proteins, which have been purified using recombinant DNA and cell culture technology. So the L1 structural proteins self-assemble to form HPV type-specific virus-like antiparticles. Thus, vaccine administration then would trigger the vaccinee's immune system to recognize these particles as foreign antigens and activate an immune response. Neutralizing antibodies are then generated that block HPV infection at mucosal surfaces. So HPV vaccines also contain adjuvants to enhance the immune response. And very importantly to remember is that HPV vaccines don't contain any live biological products or viral DNA, and they are therefore non-infectious, contributing to the safety aspects. Also, HPV vaccines don't contain any antibiotics or preservatives. So the first HPV vaccine was licensed about 18 years ago in 2006 with a primary goal of preventing cervical cancer. So to date, there are 6 licensed HPV vaccines available on the market. And here you can see the 3 types of HPV vaccines available containing virus-like particles which target specific HPV types. So now, as you have seen, you can move to the next slide. So as you have seen now on the previous slide, all available HPV vaccines target high-risk HPV type 16 and 18, responsible for 70% of cervical cancers, 85% of HPV-related head and neck cancers, and 87% of anal cancers. So in addition, the non-valent vaccine includes antigens targeting oncogenic HPV types 31, 33, 45, 52, and 58, contributing to cervical cancer and other HPV-related malignancies. The quadrivalent as well as the non-valent vaccine also protect against HPV type 6 and 11, which cause 90% of benign anogenital warts. Now, very important is to know and remember that these vaccines protect against HPV-related cancers and disease in males and in females. So it's not only a female vaccine. And go to the next slide. To ensure that HPV vaccine safety and effectiveness, vaccines must be stored at 2 to 8 degrees Celsius. And they should be discarded if frozen because these vaccines are freeze sensitive. The standard dose is 0.5 milliliters administered intramuscularly into the deltoid region. And when co-administered with other vaccines, it's recommended to use separate syringes, and different injection sites. Now, since licensure, over 500 million doses of HPV vaccines have been distributed. And the vaccine is considered safe and is well tolerated, with no new adverse events identified since the first clinical trials. Adverse events following immunization are generally mild and of short duration, with the most common side effects being pain at the injection site or mild fever, while serious side effects are really very rare. A similar safety profile has also been observed in immunocompromised people. So furthermore, post-licensure safety surveillance data show no association between the HPV vaccine and autoimmune diseases, nor any increased risks for GBS, Bell's palsy, CRPS, clots, infertility, and ovarian failure. So the HPV vaccine, similar to other vaccines, is contraindicated where, in the case of a severe allergic reaction to previous HPV vaccination or to a component of the vaccine. So what's also important, like with any other vaccine, is as a precaution, always postpone HPV vaccination during a moderate to severe acute illness. So while limited data on HPV vaccine safety in pregnancy, while the data is still very limited, it is reassuring. However, currently it's not recommended in pregnancy, so postpone until after the pregnancy. However, HPV vaccination is safe for breastfeeding mothers as well as for infants. Now, people have different perceptions of pain and also different pain thresholds, with up to 60% of people fearing pain, needles, and injections. So needle fear can then worsen the experience of pain and can lead to immunization stress-related responses, such as fainting. So these kind of anxieties need to be addressed to build trust in vaccination, and this is where the pharmacist can play a very important role. Now, to prevent mismanagement of cases and avoid harm, it is very important to differentiate between anaphylaxis and a stress-related response to vaccination. The clinical signs of stress-related responses shown here on this slide are brought on by anxiety related to the vaccination process. Now, because fainting is very common, individuals receiving the vaccine should be seated and observed for 15 minutes following vaccine administration. And the WHO reference shown here on this slide is really a very useful guide on this topic. Now, there is a huge body of evidence about HPV vaccines' real-world impact. These vaccines are highly immunogenic, with a serological response to vaccination being much stronger than the response to HPV infection, which is why natural immunity does not protect against subsequent infection. The benefits of herd immunity have been observed in unvaccinated populations, with substantial reductions in HPV prevalence and related disease. The long-term vaccine protection has also been demonstrated for at least 10 to 14 years, with vaccinated individuals being protected from the most harmful types of HPV when exposed to the virus later in life. HPV vaccine effectiveness is also evident from multiple clinical trials and real-world studies, which have demonstrated almost 100% protection against persistent infections with HPV types covered by the vaccine, and a significantly reduced risk of developing cervical cancer and other HPV-related cancers. So on the next slide, there's an example of a registry-based cohort study of girls and women aged 10 to 30 years living in Sweden between 2006 and 2017. So it is clearly evident from this graph showing the cumulative incidence of invasive cervical cancer according to HPV vaccination status, that HPV vaccination is associated with a substantial reduced risk of invasive cervical cancer. And then, important, the earlier the vaccine is received, the greater the benefits. And as you can see also on this graph, the age at follow-up is truncated because no cases of cervical cancer were observed in girls younger than 18 years of age. Now, the World Health Organization recommends that the primary target population should be girls aged 9 to 14 years before they become sexually active. High vaccine coverage is also very important because achieving over 80% coverage in girls also reduces the risk of HPV infection in boys. They also recommend catch-up vaccination of girls aged between 9 and 18 years at the time when the vaccine is introduced into the vaccination program in a particular country. Then in terms of secondary target populations, vaccination of, for example, females aged 15 years and older, boys, older males, and men who have sex with men is recommended. However, they state that only if this is feasible and affordable and not interfering with the, for example, the screening program in terms of cervical cancer. Now, because immunocompromised people, including those living with HIV and children and adolescents who have faced sexual abuse, are at an increased risk of HPV-related disease, it's recommended that these individuals are also prioritized for vaccination as part of the public health program. So these individuals, regardless of age or antiretroviral therapy status, should receive at least 2 HPV doses with a minimum of 6 months interval, and then also where possible 3 doses. On the other hand, travelers and healthcare workers are not at an increased risk of contracting HPV infection and should follow the vaccine recommendations for the general population. Now, current evidence supports the recommendation of a 2-dose schedule for the primary target group from 9 years of age and for all older age groups for which HPV vaccines are licensed. And the minimum interval between the first and the second dose is 6 months. When it comes to multi-dose schedules, it's always recommended to consult with the particular vaccine's product information. Then as an off-label option, a single-dose schedule, you can go to the next slide. So as an off-label option, a single-dose schedule can be used in girls and boys aged 9 to 20 years. The current evidence suggests that a single dose has comparable efficacy and duration of protection as a 2-dose schedule and may offer program advantages, be more efficient and affordable, and contribute to improved coverage. So, from a public health perspective, using a single-dose schedule can offer benefits that outweigh the potential risk of a lower level of protection if immunity wanes over time. However, there is no current evidence for this. So, in summary, HPV vaccines are very safe, including for special populations. They are highly effective and are recommended for both males and females. Vaccination significantly reduces the risk of developing cervical cancer and other HPV-related cancers. And then lastly, HPV vaccines provide long-term protection based on evidence that we have now for at least 10 to 14 years as well as benefits of herd immunity. So here are all my references, and I thank you for listening. Thank you.
Thank you very much, Professor Hannelie, for the rich and insightful presentation. Now I want to introduce you our third panelist. Olchuko Izila is a PhD student and research assistant in the Department of Health Outcomes Research and Policy, Open University Horizon College of Pharmacy. She earned a Bachelor of Pharmacy degree from the University of Nigeria. Her research interests include immunization and shared clinical decision-making, to which she has made significant contributions. She has authored several articles in peer-reviewed journals and has presented her findings at both national and international conferences. Olchuko, the floor is yours. Over to you. Thank you so much.
Thank you, Hannelie, for the wonderful introduction. And to our esteemed audience, thank you very much for joining in on today's event. I would like to give a huge shout out to pharmacists here all over the world, and in a special way, my fellow pharmacists from Africa. I want you all to know that we see and appreciate the great work you are doing for your patients and your communities. Today is the International HPV Awareness Day, and it's a great day to discuss how we can contribute to HPV prevention efforts. This section, we will take a look at some of the national and global targets for preventing HPV-related diseases and cancers. We will also explore how we as pharmacists can contribute to HPV vaccination efforts. Next, we'll talk about the best practices for effective patient communication and counseling on HPV vaccination, and how we can address common concerns and misconceptions. And we'll identify useful tools and resources that will help us in achieving this. And lastly, we'll talk about how we as pharmacists can collaborate with other healthcare providers and public health agencies to boost HPV vaccination uptake. As the first presenter hinted, cervical cancer is the most prevalent of all HPV-related cancers, and as a result, most global and national strategies tend to focus on it. Recently, the World Health Organization announced the 90-70-90 target as part of its 2030 global strategy to eliminate cervical cancer. This strategy has been adopted in most of its member nations in Asia, in Europe, in Africa, and America. The goal is to have at least 90% of adolescent girls completely vaccinated against HPV by the age of 15. And to have 70% of women screened for cervical cancer when they turn 35 and again when they are 45 years. And lastly is to have 90% of women who have invasive cervical cancer and pre-cancer lesions treated. Beside the World Health Organization global strategy, different countries also have their own unique targets against HPV. For example, in the United States, as part of the 2030 Healthy People goal, we intend to increase the proportion of our adolescent boys and girls who have received complete doses of the HPV vaccination to 80%. Other countries like the United Kingdom intend to eliminate cervical cancer completely by 2040. I encourage you today to take a moment after this presentation to review your own country's specific target, as that will help you better understand the importance and how you can contribute to the broader public health efforts against HPV. You may be wondering, why are pharmacies critical to HPV vaccination and cancer prevention? The quick answer is because of our accessibility and our expertise. Community pharmacies and pharmacists are everywhere in the communities, even in places where we call medical deserts. These are places that have little to no medical facilities. Pharmacies offer walk-in services. They offer extended operation hours, which makes it more accessible and convenient for patients. Pharmacists are also seen as trusted medication experts, and that equips them with the knowledge and skills to educate their patients about medications and HPV vaccines. In fact, research has shown that patients are twice as likely to visit their pharmacist than their physician office. Now, this is important because it gives pharmacists greater opportunities to interact with patients and build rapport and trust with these patients, placing them at the center of increasing HPV awareness and education around HPV. Is that we can actually contribute to HPV vaccination efforts. The first one is by proactively screening for and identifying eligible patients who will benefit from HPV vaccination. Now, this is particularly important for people who are older than 15, as they are not often the focus of HPV vaccination campaigns. Pharmacists can do this screening by reviewing patients' vaccination records or asking patients whether they have received the HPV vaccine, or if they have even heard of the word of the HPV and HPV vaccination. Pharmacists can also review their immunization registry in countries where these are available. When patients enter your pharmacy, it is a great opportunity for you to educate your patients about HPV. Tell them about how HPV is implicated in several cancers and how receiving the vaccine can help them prevent this. Tell them about HPV screening, which can also protect them from having HPV-related cancers. Community outreach is also a great way to reach a wide audience. Pharmacists can do this by collaborating with local schools or communities to reach a wider audience and increase awareness about HPV. Now, this is a great way to build trust within your communities and make this easier for when you want to introduce mass vaccinations. Like I said earlier, pharmacists are everywhere, and they are a great asset to reach very hard to reach populations. How can pharmacy do this? They can do this by collaborating with public health agencies or other physicians to set up vaccination clinics in their areas. And in regions where pharmacists are authorized to give vaccines, pharmacists can go ahead and stock up these vaccines and administer them, as this is a great way for people who do not have any other way of getting these vaccines, especially in areas like the medical deserts. And lastly, it is important for us to raise awareness about our roles as immunizers. Research has shown that, particularly for pediatric groups, adolescents, most parents are unaware that pharmacists are immunizers. So it's very important that we raise awareness about this. And how can we do this? By talking to patients, using posters in our pharmacies, and letting them know that, yes, we provide vaccinations. The importance of this is that it increases awareness about us as immunizers, and it sets us at the forefront of healthcare providers against HPV. There are evidence-based practices that you can employ when you are counseling your patients about HPV and addressing their common concerns and misconceptions. Now, two of these approaches have been shown to be very effective in the literature and is employed based on different situations. The first one is the presumptive or announcement approach. Now, the importance of using knowing the particular communication approach to use is because it has been shown that the communication style that a provider, in this case us as pharmacists, employ affect the way patients perceive HPV vaccine and how whether or not they are willing to accept this vaccine. The presumptive or announcement approach is best used when you want to save time and there are no concerns about the vaccines from the patients. Now, the goal of this is just to announce to the parents or the individual that they are due for the vaccine. An example of how you can have this communication is, hi, your daughter or your child is 12 years old and is due for these vaccines. You mentioned them, HPV, influenza. I will give it to her at the end of today, after today's visit. The other approach is the conversational or participatory approach. Now, this approach is best employed when you notice that the individual or the parent has certain concerns or questions about the vaccines, and there is need to initiate an open discussion to address these concerns. Now, why this approach is more time-consuming, it leads to a greater patient satisfaction with the discussion and builds better trust and rapport with the pharmacist. So my advice is read the room, know when to adopt each method based on the patient and the situation at hand. Then the next one is the guidelines. We advise that you follow the national recommendation for HPV for your adolescents and adults in your country. Now, the reason for this is that there are reasons for recommendations for each age group. Now, for adolescents, we don't do recommendation based on risk. We do it based on age. So pharmacists are to recommend these to adolescents of all age group, regardless of whether they are at risk or not. And in the United States, we also have additional recommendations like the shared clinical decision making that is used for people between the ages of 27 to 45. Now, this recommendation is to initiate conversation with the patient and to talk about their risk of HPV and whether or not they will benefit. Now, why this is important is because at this age group, most people have been assumed to have been exposed to sexual activity. So since they're already exposed to the virus, the vaccine might not be as effective as much. So there is need to talk about their risk and whether it is possible that they can still benefit. So I advise that, as I said earlier, please take a moment after today's presentation to also check out what the recommendation says in your country, as that will help you give confident recommendations to your patients. Then the next one we'll talk about is the recommendation strategy you employ. Strong recommendations for pharmacies from providers have been seen as the greatest predictor of whether patients access vaccines or not. So we advise that you provide very straightforward, very strong and consistent recommendation that is uniform across all interactions with patients. Please back your recommendations with evidence. Explain to your patients about the safety and effectiveness of the HPV vaccine. And it's important that when you are discussing HPV in routine vaccine discussions, especially with parents and other patients, that you introduce it very early. The order with which vaccines are introduced influences the perception of their importance. People tend to think that when vaccines are introduced late in the discussion, it is not as important as those that I talked about earlier. And during discussion, we don't advise that you single HPV vaccine out. Discuss it like how you would discuss MMR, discuss it with your patients like how you discuss influenza, because that helps to reduce the stigma around it and establishes it as a normal part of adolescent or adult immunization. And rather than talking about HPV in cancer as a vaccine for sexually transmitted infection, we advise that you focus on it as a vaccine against cancer, because that has shown to increase acceptance among parents and help to allay their fears of their teen engaging in sexual activity because they received the vaccine. And if you have this vaccine in your pharmacy readily available when patients come and you educate them about them, we suggest that you please recommend the same day vaccination. What we mean by this is that after the recommendation, that you please suggest to them that you would like to administer the vaccine that day. The purpose of this is to avoid missed opportunities to vaccinate and to ensure that parents their patients receive these vaccines when they need it. And in situations where we have patients are eligible for second or third doses of vaccine, we advise that you set up reminders for yourself and for your patients, as that would help to ensure that the subsequent dose is remembered and is administered as at when due. Now, during your interactions with patients, you might hear some of their concerns and misconceptions that you need to address, and that includes particularly for parents, the fear that receiving this vaccine might encourage their teens to engage in sexual activity. There are also concerns about the safety and effectiveness of this vaccine. There are misconceptions that causes women not to give birth later in future. Some people think that they don't even need the vaccine, and men think it's only women that get that contract this virus. And one of the tools that you can use to address these concerns, beside the best practices we have discussed, is the Aspire framework. As you can see, the Aspire framework includes most of the practices that we've discussed earlier, like assuming that the patient wants to get vaccinated and sharing credible sources of information to counter some of the misconceptions patients might have. You also have to present strong recommendations to vaccinate. The key aspect of this framework that I want to highlight is the fact that if you have positive stories, like you have nephews or nieces or cousins, family members, friends that have received the HPV vaccine and nothing bad has happened to them, or people that we know that have received it and they still gave birth, or even if you have received the vaccine and you are okay and the vaccine is safe and effective, patients tend to understand better when they can relate to your experience, and they tend to trust you better and trust your recommendations better. We also emphasize on proactiveness. Initiate discussion with your patients about these vaccines and address some common questions they might have proactively. One other important aspect of this framework in addressing common concerns and misconceptions is the need to respond to questions and to actively listen. The listening part cannot be overemphasized. Patients want to feel understood. They want to understand, they want to know that you understand their concerns, and we encourage you to take your time. I know pharmacists are very busy. I worked as in clinical pharmacies in the past, and I know how busy we can get sometimes. But if we can take a moment to actually listen to our patients, that can encourage them to get this vaccine and to reduce vaccine hesitancy. And in situations whereby you talk to your patients and they are still not able to agree with you that day, please let them be for the moment. Give them resources that they can review when they get home, and offer to bring up the conversation when next they visit the pharmacy. With that, we hope that they can come around and get to understand and hopefully get vaccinated eventually. Now, there are other ways of resources that you can employ. Please, as I said before, familiarize yourself with the child and adult immunization schedules in your country, as that will help you understand the timing for vaccination, the individuals who needs to get vaccinated against HPV. It helps you better understand some common concerns and how you can address them. I know it's not easy to keep updated with the always changing schedules, but please take a moment and equip yourself with this knowledge, as that can help you better understand and address some concerns. We also have these resources by the U.S. Centers for Disease Control and Prevention. Now, this resource on talking to parents about HPV vaccine handout is very educative. It gives you common concerns and questions parents have about HPV vaccines and how you can address them in a layman's language that patients can easily understand. We also have resources by TechNet and WHO that focuses on communication strategies for different communities that you can use to improve HPV vaccination uptake. About resources and how we can make great impact. Let's now dive into the teamwork aspect of this topic, as that can even help us make a greater difference. Now, there are different ways pharmacists can collaborate with other providers and public agencies to improve HPV vaccination uptake. And one of them is patient referral systems. Pharmacists that are not authorized to give immunizations can still educate patients and refer them to their physician offices to receive these vaccines. It goes both ways. You can also collaborate with physicians to refer patients to your pharmacy to receive the HPV vaccines if you are authorized to administer them. We also encourage pharmacies to be aware of the documentation processes in their country for vaccinations. Please report your vaccination records, as that helps ensure accurate records, and set up a system that allows for data sharing, because that helps you to understand how and when patients are due for vaccines, different vaccines. We also recommend that you set up reminder systems that will notify you and the physicians of when patients are due for vaccination. Physicians and pharmacists and other public health agencies can also combine resources and expertise to increase awareness about HPV and conduct mass vaccination programs for HPV. Our professional organizations can also collaborate with public health agencies to advocate for pharmacy expanded role in just like FIP is already doing. And this is very beneficial because it helps us advocate for our interests, not just for expanded role, particularly for reimbursement, which is an issue here, even in the United States. In conclusion, I want to say that pharmacies are very crucial for preventing HPV-related diseases and cancers. What makes us stand out is our accessibility, our expertise, and our trusted relationship with patients. We can take advantage of this and by educating patients and improving HPV awareness and uptake. Thank you all so much for listening. These are my references.
Thank you. Thank you very much, Oluchukwu, for this very insightful presentation. And I think you've given so many tips and actually answered some of the questions on the Q&A already. But yeah, there's a lot that pharmacists can actually do to build confidence in vaccination, particularly HPV vaccination. I'm looking at the Q&A. I wonder, there's one question, maybe, I don't know, Rowan, would you like to answer this? The question is about how to prevent the recurrence of HPV. And then further to that is the issue about natural immunity from HPV infection may not provide protection against subsequent infections. So the person is Isabel Young. Does that mean that we should still encourage HPV vaccination in those who already have genital warts / cervical cancer? As a counter argument is that the vaccination does not prevent a person against subsequent infections, and therefore they would not want to get vaccinated. Maybe you can try and answer that.
Yes, thank you. So how to prevent the recurrence of HPV? So as we know, HPV is a virus that's sort of fleeting. It comes and goes, and the body has the natural immune system is able to, even an unvaccinated patient, for example, is able to clear the virus occasionally. But we do always encourage the vaccination because it does provide that ultimate protection, upwards of sort of that 90, some people quoting 100% effectiveness of preventing that recurrence. And it is most recommended, and the best efficacy of actually preventing actually getting HPV and actually getting recurrent or persistent infection is before first sexual debut. So that's why we sort of encourage, and most national immunization programs do encourage vaccinating boys and girls before the age of 9 to prevent that. Now, in the second question regarding how to encourage, HPV vaccination in people who have already, for example, have genital warts, I'm not sure what they mean by cervical cancer, because then that's sort of a different I suppose you've developed a cancer now, and that's sort of a different management principle. But if you've developed genital warts, or for example, precursor lesions, so CIN, cervical intraepithelial lesions, which are associated with the most common types of HPV. Usually, even in these situations, we would still recommend the vaccination because they have the wider range of HPV subtypes that we vaccinate against. And normally, for example, I answered another question that was related to if somebody had HPV-16, for example, HPV-18. Once that was actually managed and was referred to a specialist, and it was managed, and the patient went back to a negative HPV result, we would then sort of recommend vaccinating in that case. The effectiveness of that vaccine is not as effective as if you were getting it before first exposure, but it's still effective against preventing recurrence. So I'm hoping that answered that question. It's a bit more complicated depending on the patient situation, to answer it in a very brief way.
Thank you very much. Yes. I think you've answered very well. There was a question about the 3 doses. So the doses, the World Health Organization recommendation is 3 doses for specifically immunocompromised people, but always consult with the product information, because depending on the situation, the age of the person, and so forth, the specific vaccine, the product information would recommend the number of doses. Also, in terms of there was a question about the secondary target group contraindications, if it's the same. So the contraindication in all cases would be if the person has had a previous allergic reaction to the vaccine itself, or to one of the ingredients in the vaccine. So that's something that one always need to bear in mind. There was a question, I think, Oluchuka, if you can maybe answer that one. Glidal Gomen. In our country, most of the families still hold on the belief of being not vaccinated as a student who is a part of the healthcare team. What can I do to invite them in being vaccinated, and how can I spread this information and educate others, especially in our country, who have this belief? So your question also centers around someone in the healthcare team. So what I can also mention is we need to bear in mind that healthcare workers themselves are also vaccine hesitant. They are not immune, to vaccine hesitancy. So, the way in which we approach the public and the community, we also need to consider healthcare workers. But Oluchuka, if you can maybe address this question.
Thank you so much for the question. Like you said, Dr. Hannelie, I agree with you that we, as healthcare workers, we also have our perception of the safety and effectiveness of these vaccines, and that affects the kind of recommendations that we provide to our patients, who can also sense our doubts. And most times when we feel doubts about these vaccines, we do not even recommend them to patients. Now, going back to the question on how he can address these concerns, I'll say the key is always education. He has to educate his colleagues, his fellow colleagues, on how it's very important for them to understand the safety and effectiveness of these vaccines and the need for HPV vaccination, and to disallay their own fears and doubts about these vaccines. He can also do this by organizing events to also educate and inform them about this as well.
Thank you very much. Yes, and you will see in the communication guide, when we speak to patients or to people, it's always important because they look up at the pharmacist, or they look at the pharmacist as a trustworthy person. We are healthcare workers, so we are scientists. So they usually, or when they speak to the medical doctor, they usually want to know what you recommend. What is your recommendation? So it's very important to always use this presumptive approach where you go out from the standpoint or the belief that this person is going to vaccinate. So, be very confident and make a very strong recommendation. And I think what is actually an advantage with the HPV vaccine is, your recommendation should always, it prevents cancer. People, when they hear that, it's very convincing. So always to use that kind of approach when you speak to people. I think also very important is, like you said, indeed, is to engage with other people in the community, because in some communities there are certain people or leaders that are being trusted more compared to others. So get those people on board, make them understand, and then try and engage with the population, in that way. There is another question here. Are there higher chances of vaccine failure after sexual debut in both sexes? And how best can a pregnant woman be vaccinated? Any special precautions? So, the earlier you vaccinate, the better. So it is important to vaccinate at the age of 9. That's why they recommend that. But it's never too late to vaccinate. And then in terms of pregnancy, like I mentioned, at the moment, the data is quite assuring in terms of pregnancy, the safety in pregnancy, but the data is still limited. So it's not recommended at this point in time in pregnancy, because they don't test these vaccines in pregnant women. So women who are vaccinated and they only, find out later on that they've been pregnant already at the stage of vaccination. This is how this data is actually collected. But the data looks, quite encouraging at this point in time, but it is not recommended. So the recommendation is to postpone vaccination until the baby has been delivered, and then you can vaccinate in the case of pregnancy or after the pregnancy. I don't know if, Rowan, would you like to add? I mean, you're a gynecologist. Would you like to add to this?
Yeah, no, that's exactly what we would say as well. So as most things, medication and vaccines and things are not tested on pregnant people for obvious reasons. And so we would recommend exactly as you said. So often we would have cases where exactly that, a woman might have been vaccinated, and they found out they're pregnant, and we often reassure them that, the likelihood of anything, of this being an adverse effect on the pregnancy is very, very, very low. But we would just sort of recommend normally, if a pregnant patient was to come, to just defer vaccination until after pregnancy, or after that pregnancy index, so after she delivers. And exactly as you said, yeah.
Good, thank you. Thank you very much. There's one question here. Oh, here's another one. Hannah, I would wish to know if a female in her early 30s who's had genital warts and recovered from the warts and had a clean pap smear, can such an individual benefit from the HPV vaccine? Maybe, Rowan, do you want to answer this question?
Yes, I believe so, because there's still an extended, so even with the Gardasil 9, for example, you've got that extended subtype, and I think we're going to be bringing out even more and more to extend the subtype. So at the moment, yes, definitely. So even with a history of genital warts, that's not so much as concerning as more the risk of sort of really the cancer risk, which is what most people are really concerned about. And so, yeah, we would definitely recommend vaccination because of that extended subtype protection.
Yeah, especially the vaccines containing more subtypes compared to just 16 and 18, although most cervical cancers are being caused by 16 and 18, there is also a certain percentage being caused by these other subtypes. So yeah, I mean, vaccination is always the answer. Never too late to vaccinate. There's one question from Marisa. It's in, I think, Portuguese, something about Gardasil, but unfortunately, I cannot understand the question. If someone else can come to the rescue, Gardasil, and then something, then we can try and answer that question as well. And then there, while someone might be able to answer, yeah, there's also one question from where is it now? Glidel from, hang on, sorry, let me just get it. Oh, Korali from South Africa. I think this is, so it's all about, you know, teenage pregnancies, HIV, and so on. Asking, would it be possible to give the 3-year contraceptive implant plus, when registered, 1 dose of 6-monthly subcut PrEP when give HPV vaccine? I think this is a kind of a policy question, which is not something that we can answer. So in South Africa, the HPV vaccine is given at the age of 9 years. Within the school health program. I don't know if any of the others would like to say something about this question. But I would say,
I don't see, yeah, it would, like, again, it would have, like what you were saying, I guess, based on local policy, but I don't see a reason why you couldn't give the vaccine at the same time a contraceptive implant. That would, I don't think there would be a contraindication at all to that. It's sort of opportunistic vaccination, I guess, at that time, or opportunistic contraception, depending on which one you're doing first. But so I don't see a reason why you couldn't do both.
yeah. And then, you know, depending on the age and whether the girl has already been vaccinated, no, and depending on the country and the program where the vaccine is being made available, like, for example, in South Africa, the vaccine is not available at this point in time within primary healthcare clinics. So specifically given, you know, twice a year during a school health campaign. But I mean, it is also available in the private sector. Sorry, Hannelie, I don't know, do we still have more time for questions?
I think now we should wrap up.
Okay.
Yeah,
Sure.
we have only 8 minutes.
But I hope we've answered most of the questions, and I'm sure, you know, when you guys are going to go to all the information that's now being made available, as well as the presentations, you can look at them again. Then hopefully you will find answers to all these questions. So just to make a few remarks, I think this was really a great and very insightful session. And as I said, especially as we are celebrating HPV Awareness Day today, and I mean, it's true that the global burden of HPV-related diseases remains significant, although we've especially in lower and middle income countries. Although we've seen in high income countries like Sweden, the UK, Australia, where we've seen significant benefits of HPV vaccination. But then, yes, something else that is really concerning is the increase in all these other cancers like oropharyngeal cancer, penile cancer, anal cancer, and so on. Then secondly, vaccination, you know, regular screening and treating early cancerous lesions are really critical strategies in reducing the burden. We've seen that these vaccines are really a life-saving intervention. They are safe. They're very effective with a long duration of protection. And then lastly, yes, pharmacists are trusted by patients. They are accessible. They are scientists. So we can actually explain to people, you know, the science behind vaccination, which will make them understand what this is all about. So just to conclude, you can see that you can access all these FIP digital events at events.fip.org. So if you can just move to, yes, here's the slide. So all digital events, and there's literally hundreds and hundreds of them. They can all be accessed at this link. And then just before we are going to conclude, I would like to direct your attention now to the 83rd FIP World Congress of Pharmacy and Pharmaceutical Sciences, which will be held this year in the beautiful Copenhagen, Denmark, from August 31st to September 3rd. This past year in 24, it was in the lovely Cape Town in South Africa, but this year we're going to Copenhagen in Denmark. And the theme is Pharmacy Forward, Performance, Collaboration, and Health Transformation. So it's a great opportunity to connect with colleagues from around the globe. If you've never attended an FIP conference, you have to make sure that you attend this one, to share best practices, explore the future of pharmacy in a dynamic and rapidly evolving healthcare landscape. So if you are interested and you want to learn more about the conference, you can visit the conference website at copenhagen2025.fip.org, and we hope to see you all there. I would also like to then just highlight a few key focus areas of the conference and some important deadlines. So the sub-themes this year are making it sustainable, strengthening global health through pharmacy, putting pharmacy first, making the system work, enhancing healthcare efficiency, and making it personal, tailoring healthcare to individual needs. So these will be some of the sub-themes of part of this year's conference. So the dates that you need to keep in mind, the first one is the abstract submission deadline, and it's around the corner on the 17th of March. Then on July the 2nd is early registration fee deadline. And then on the 11th of August, there's the second registration deadline. So for full details, you can scan the QR code or visit the website at Copenhagen2025.fip.org. And as I said, you know, if you haven't attended an FIP conference, really make an effort. And we hope to see you all there in Copenhagen. And that brings us then to the end of this exciting afternoon. And I hope you really enjoyed it. All of you, you've learned a lot. I've certainly learned a lot. And yes, finally, thank you very much again to all the speakers, all the organizers from FIP working relentlessly behind the scenes. And thank you everybody for taking the time to attend this event today and help, you know, in helping it, making it a huge success. Thank you very much.